All right, my job is to say everything that's already been said in 8 minutes without repeating anything that's previously been said in this session. This is my conflict of interest disclosure. So I also have 8 things to say in 8 minutes here. Where does this field need to go? First is determine the real size of the unmet need and where all the untreated patients with MR are residing right now. This has been shown multiple times over the years at meeting that there's 4.6 million patients with MR. Only 55,000 or 3% of them are getting surgery. So where are the rest of them? Are they in heart failure clinics, and how do we get them out? Certainly they are not falling out of trees just waiting to be treated right now. Second, we need to clearly define the disease etiology. We have this new term called dunctional or mixed disease. This is not a disease etiology. It's a classification to get paid. The real classification is exactly like Maurice just said earlier. We have primary or degenerative mitral regurgitation. That's Carpentier type 2. We have secondary due to ventricular dilatation and tethering of the leaflets. That's what Maurice called FMRV. And we have secondary due to annular dilatation or Carpentier type 1. So there's basically 3 diseases that we're treating, and there's 2 types of secondary diseases, and I think we're going to see the new guidelines reflect this. And what I would say is Carpentier got this right 40 years ago. We're treating type 1, type 2, and type 3B disease. And the classification was right way back then. And if we look at what's being treated with MitraClip right now, this group of patients with mixed or neither, I think is not a sufficient classification at the current time. Really? I mean, what's being called mixed disease is really secondary disease with a severely tethered posterior leaflet. Thirdly, we need to define the responder population. To reconcile the difference, first of all, I would say 3 things. Reconcile the discordance between COAPT and MITRA-FR. I was part of COAPT, so naturally I think that's right. But the Europeans feel just as strongly about MITRA-FR. We have to truly reconciliate these differences. Second, the issue that Marty brought up of proportionate versus disproportionate MR. And thirdly, guideline-directed medical therapy needs to be optimized and maintained. One of the things we have learned from COAPT is guideline-directed medical therapy really works, but only 20% of patients referred in with functional MR really are on optimal guideline-directed medical therapy. So this is the 2 trials, Mitral-FR and COAPT. COAPT showed that the lower rate of heart failure hospitalizations at 24 months. The rate of death or heart failure hospitalization at 1 year did not differ, and 2 expert editorialists solved this for us by saying there's a possible role for the device. Okay? So we've got 2 trials done of the same group of patients, same disease, same patients, same time frame, by the same device, and totally opposite results. Now maybe this begins to explain it. Paul Grayburn and Milton Packer of defining proportionate versus disproportionate FMR. Here's the patient on the left with disproportionate mitral regurgitation, on the right with proportionate mitral regurgitation. This is a very hard concept to understand. We need to validate it. We need to understand it and explain it better. But basically, the more severe the MR and the smaller the ventricle, the greater the chance it's going to respond to therapy. And this is an overlapping Venn diagram of the COAPT versus MITRA-FR trials. This has not been validated by an independent core lab, and it is in the process of doing it, but we need to reconcile these 2 trials. And here's an analysis that Drs. Grayburn and Packer have done about all the different trials in heart failure, looking at where they fall in this concept of proportionate versus disproportionate MR. Number 4, we need to formalize the structure of structural heart disease. And what I mean by that is we need a new heart team for mitral, including heart failure specialists and imagers, and a new breed of actual interventional imagers. Valve centers of excellence, formal training in structural heart disease, and determine how best to assess outcomes. And that's not going to be as easy as TAVR. In TAVR, we could look at mortality and know whether we're doing well or not. It's not going to be that easy in mitral. And being able to determine who has adequate correction of mitral regurgitation or who does not is going to be a very difficult thing to assess long term. So this is the TAVR heart team, which was led by an interventional cardiologist and a surgeon. This is the TMVR heart team, which not only has an interventional cardiologist and a cardiac surgeon, but a heart failure specialist and an imaging specialist. This is the TMVR heart team going forward. All of us have kind of learned on-the-job training for structural heart disease, but I think it is time to formalize the training in structural heart disease, and there are discussions ongoing at the present time of an ACGME certified structural heart training program, some of which the concepts are outlined here. There's also a proposal for operator and institutional recommendations for transcatheter mitral valve repair, similar to what we have for TAVR. And then there's a expert consensus document defining optimal care by valve centers of excellence of two levels of care, a primary and a comprehensive valve centers for the treatment of structural heart disease. So it is time for this to become more structured. Fifth, the treatment approaches. Determine who is best treated by repair versus replacement, and there are lessons from surgery there. Secondly, TMVR is going to have to be done by a transeptal approach so that the safety profile is close to MitraClip, because as you've heard, that will be the comparator. We need to make edge-to-edge repair not a burnt bridge that will preclude TMVR, and Paul gave you a little bit of an idea how that possibly may be done. And we really do need to figure out Mack, because we aren't even close to that. The mortality is still unacceptably high by all approaches. Next is expanded indications and treatment options. So we will see a trial of transcatheter mitral valve repair versus surgery in intermediate risk patients that's likely to start early next year. We will see staged and combined procedures for multi-valve disease. So in other words, TAVR for aortic stenosis and a MitraClip for mitral, either in the same setting or more commonly, and what will be done in the near future, as a stage approach. And we will eventually see combined procedures of using multiple devices in a single valve. So a transcatheter chordal replacement and an annuloplasty band, or a MitraClip and a millipede. Second, we need to get reimbursement for secondary mitral regurgitation. We have FDA approval for it, but we aren't even close to getting CMS reimbursement for this yet. And this is something that is overdue to be solved at the current time, and it is precluding treating patients. And lastly, we need to have patients going forwards. And what do I mean by that? Well, if we look at the timeline of TAVR, in 1988, the idea happened. In 1989, the first animal was done. 2002, the first human. 2007, received CE mark. 2012, FDA approval. And by 2019, there were 3 devices approved in the U.S. with 58,000 patients treated in 2018. TMVR started in 1997, and the first animal was done in 2000, and the first human was done only a year after the first human TAVR was done. CE mark happened the same time that it happened with TAVR. FDA approval for a limited indication for primary MR also happened the same thing with TAVR. But here we are in 2019, we have 1 device, approximately 10,000 per year in the United States. So this is an editorial that I wrote for Surgical Journal in 2008, looking at the field. My conclusion was the challenges of percutaneous mitral valve therapy remain formidable, and clinical success is by no means assured. And I think that still holds true in many ways 11 years later. I think you can look back at the last 11 years and it kind of looks like this. It's a junkyard full of wrecked cars. If we look at the devices I outlined in that article in 2008, this is them. What's still going today? eValve, we're now called MitraClip. The Caroline device by Cardiac Dimensions is kind of sort of still alive, as you've heard from Marty. Everything else has gone to the trash heap. So here we are with MitraClip, and where are we going? Where are we now, and where are we going in the future? Well, you saw Marty said there's 67 devices. This is repair devices. This is replacement devices. And I better say that all of these are not going to survive by any means. This is the volume of what's happened with TAVR versus SAVR. Transcatheter mitral valve therapy is not TAVR redux. We can't have the same expectation. The runway for TAVR is a lot shorter than it's going to be for TMVR. It's going to take a lot longer to get there. So where does the field need to go in summary? We need to determine the true unmet need and where the patients are. We need to follow disease classifications. We need to best define the responder population, improve and refine treatment approaches, formalize treatment of structural heart disease, expand indications and treatment options, get reimbursement for secondary MR, and we need to have patience while all this happens. So transcatheter mitral valve therapy, can you put sound on? If not, it's okay. It may look hard, but we can figure this out. There always is a secret sauce. Thank you.